So what I hope today is to really review what's the latest state of affairs, if you will, with HRT. Is it safe? Are they not? How long should we use them? What are the difference between the different dosage form? Some information on testing. How should we be monitoring with? And then really the difference between synthetic and then bioidentical hormones, because there was a lot of questions. So as you guys know, really currently we have about 2.5 decades of women that really were yanked off their hormone because of the Women Health Initiative trial that was published back in 2002. So we have literally 25-year period where women, at least most women, did not receive the benefits of HRT. So we saw a huge decline in the use of HRT in women and therefore some of the beneficial effects. Now, 12 years ago, we started to see smatterings in the literature. Maybe hormones are not bad. Maybe we need to relook at this. What was the goal of the Women Health Initiative trial and so on? So studies started to be published about 12 to 15 years ago, really all rebuking potentially the findings of the Women Health Initiative trial. So we started to see articles like this: menopausal hormone therapy and long-term all-cause and cause-specific mortality might be reduced, and that we don't really see all-cause mortality rates were not significantly different for the hormone therapy group versus the placebo group. So they were not increasing risk. And then we started to see what we call the timing hypothesis. So then most of the studies about 5 to 7 years ago showed, okay, hormones were okay to use. I think that the benefit probably outweighed risk, although you have to do some risk stratification for the patient. But really now we have this, initially it was a 5-year window where we think hormones and the benefit, hormones are helpful, the benefits outweigh the risk. And then B, the next set of studies came out and said, now we can use them for 10 years. And I think the biggest question, it was the timing hypothesis that all of you guys were asking. Okay, we know at least hormones are helpful the earlier we start them. So most of the data shows the earlier we start hormones in the perimenopause to menopausal stage, that is benefit from those. And also, and we had this 10-year window. And a lot of you were saying, what happens after that 10-year window? And then lo and behold, the study was published in 2022. And literally, I reached out to Dr. Clement McDonald of the NIH almost immediately as soon as I saw this, because I was like, oh my God, I think our questions are answered now, because this study looked at the effects of hormone therapy on survival, cancer, cardiovascular, and dementia risks in 7 million menopausal women. But this was over the age of 65, right? So these people, obviously the average age of menopause in this country is about 50 years of age. And therefore, these women were on hormones for at least, let's say, an average of 15 years. And some of them were 90 years old. So they were on hormones for a very long time. And this really, we said, oh my God, this, I think we will answer the question is, what should we do after this 10-year magical window? So a lot of the data with the 7 women trial, and I actually brought Dr. Clement McDowell to lecture our A4M fellowship modules and our endocrinology module 1 to really review the study data and obviously educators from the NIH. So the conclusion was, for women post-hysterectomy, estrogen is all good. Obviously, for women with a uterus, estrogen alone is not safe, because obviously if you don't cycle them with a progestin. And here you have to understand, they're still confusing a lot of these nomenclature for progesterone versus a progestin. Even when I reached out to Dr. McDonald and I said, were they all using a progestin, which is the synthetic progesterone-like medications? They said they did not stratify them really between using bioidentical micronized progesterone versus the synthetic progestins. So the big group that houses both the progestins and progesterone is called progestogen. And so when you read an article in the literature, if it just says progestogen, that doesn't really tell us if they use natural micronized bioidentical progesterone or if they used a synthetic progesterone acetate. So that's very important when you dissect the literature and look for these and what they use, whether synthetic or bioidentical estrogen, synthetic or bioidentical progesterone, and so on. because really the physiological effects are very different between the two. So for women with the uterus, estrogen alone, obviously, if we don't cycle them with a progestin or a progesterone, that increases the risk for endometrial cancer. And obviously, if you have an intact uterus, you must use a progestin or progesterone to decrease the likelihood of endometrial hyperplasia. And really, the regimens that have been shown to cause endometrial protection in the literature is really 200 milligrams of micronized progesterone taken 12 to 14 days per 28-day menstrual cycle. There is some data also now to look at 100 milligrams taken daily for endometrial protection. Obviously, progestins can be used. They're very good at shedding the endometrial lining, like the medroxyprogesterone acetate, but you really don't want to use the synthetics because the physiological effects as compared to cardiovascular protection, brain protection, heart protection is very different from the synthetic progestins versus progesterone. So unfortunately, just because this is a short time to present lots of data for you, I can't show you all these effects. Now, the main finding in the studies, and this was really very exciting information because what they showed in their Cox regression analysis that overall estrogen therapy use was associated with a significant almost 20% reduction in all-cause mortality as compared to no estrogen therapy. So now we know that women, if they're using estrogen, even after this 10-year magical mark, and the biggest concern was cardiovascular disease, that we still saw roughly a 20% reduction in all-cause mortality, and obviously heart disease is part of that. We also saw an associated reduced risk of breast, lung, and colorectal cancers, and actually others have reported this. But the interesting part is we also saw an associated risk reduction for congestive heart failure, VTE, strokes, and dementias relative to no estrogen therapy use. So he called it, Dr. Clement was very clever. He liked Wizard of Oz. So he said, this is the good witch of the South. So risk reduction, and this is again another critical point, risk reduction was significantly greater for bioidentical estrogen versus conjugated equine estrogens, or as I refer to them, 4C estrogens. Vaginal and transdermal were safer as compared to oral. No surprise there, right? We know oral estrogens are associated with thromboembolic disease, gallbladder disease, sometimes lipid dysregulation, and so on. And that low or medium doses were safer as compared to the high doses. So the big takeaway was that we should use estradiol, bioidentical, vaginal or transdermal, but not oral, and then use more physiological doses, which are low to the medium doses. That estrogen progestin use was associated with a significantly increased risk of breast cancer across all types, routes, and strengths. And this is exactly when I reached out to him because we know most of the trials showed when we use estrogens with a progestin, synthetic progestogen, that the risk of breast cancer increases. Many studies have reported when we use estrogen with progesterone, which is natural micronized progesterone, bioidentical, that actually the risk of breast cancer is either nullified or actually reduced. So this is when I reached out to them, and this is where they really did not stratify the progestogen use across the different types. So again, the study showed a 20% reduction in all-cause mortality. And then the Women Health Initiative trial, conjugated equine estrogen had no association with coronary heart disease. So even the conjugated equine estrogen, which is what was the biggest concern throughout all these studies, that we increase the risk of cardiovascular disease with hormones, did not even show an associated risk, even with the conjugated equine estrogen. They saw a small increase in ischemic heart disease with estrogen therapy alone. However, it was mostly concentrated in the high dose group as compared to the low and medium. So really, this is why you want to use physiological doses. Low dose of estrogen monotherapy exhibited a 1% decrease in risk for heart disease. So when we use low dose estrogen, physiological, we actually saw a reduction in heart disease. So basically in women, estrogen is good. If they have a uterus, you have to cycle them. And we really suggest progesterone because it is definitely, the physiological actions are very different. So then they actually followed this up with the 10 million women study. So they added more patients and they continued to monitor the other ones. So among senior Medicare women, the implication, so they've looked at this now and really their study objective. So this was a large scale Medicare study aimed to assess, again, menopausal hormone therapy beyond 65 years of age. And then they looked at the health implications, routes of administration, and dose strength. So this is 10 million senior Medicare women. They followed them from 2007. They were enrolled to 2020, and they looked at all these different endpoints. So estrogen therapy, again, they saw the same thing. They saw a 19% reduction in overall all-cause mortality risk, and they saw decreased risks in breast cancer by 16%, lung cancers, colorectal cancers, and several cardiovascular conditions. They still saw a reduction of 3 to 11%. They saw better outcomes with low rather than high doses, vaginal or transdermal rather than oral, and then E2, which is the estradiol, rather than conjugated estrogens. Now, combination therapy, estrogen plus progestins, as I mentioned, they don't really delineate, although in the study they finally did. They saw reduced endometrial cancer risk, reduced ovarian cancer risk, and improved cardiovascular outcomes. Now, the data suggests that progesterone, so in this one, they did stratify them between the progestin versus progesterone. So the data suggests that progesterone, obviously bioidentical, generally has a more favorable safety profile than progestin, which is synthetic, especially for overall mortality, breast cancer risk, cardiovascular outcome. Now, progestin may have a slight edge. It's slopping the endometrial lining when combined with estrogen, but definitely for the heart protection, brain protection, endometrial protection, and most importantly, breast protection, progesterone definitely wins. So why is it important now to really start women in the right population, in the low-risk women on HRT? Because it's very critical for brain protection, heart protection, in really breast protection in some of treatment. So there is really now, as we're saying now, finally, the hormones were vilified, but now they've been vindicated. And really, everybody is chomping at the bit to become a menopause expert to really learn as much as possible about hormones because of the beneficial effects that we're reaching. Because of that, also, there's a lot of misnomers and nomenclatures out there. Everybody goes, I want natural, I don't want this, and I don't want the synthetics and bioidentical, but that's not natural. There's a lot of different terms that are thrown out there that I just want to kind of level set the field and really review that. So bioidentical hormones are plant derived. So we usually derive from yam or soy. And obviously when you see the hormones, they don't look like a yam or a soy. So obviously they undergo a lot of chemical processing to take that yam and soy and extract all these hormones from them. So I tell patients that there's really nothing natural about that process. There's a lot of chemical manipulation and processing that has to happen. The most important part for the drug manufacturers or the compounding pharmacies is at the end that they make sure that it's clean and devoid of all these solvents and chemicals and things like that. And at the end, they end up with a pretty clean, pure progesterone powder or estradiol powder. But bioidentical means they have the same exact chemical structure as the hormones that you make. And therefore, when they dock onto the receptor like a key and lock, they work exactly the same. Synthetic hormones obviously are different. They are synthesized chemically in the lab, but the most important part is that their chemical structure is very different. They do not look exactly like estradiol, estriol, or estrone. So therefore, their actions or their lock and key mechanism of the receptor, if you will, might be different. Now, conjugated equine estrogen, the estrogens as I call them, they're really made like 50% estradiol and 50% estrone. So they're very strong in how they work and things like that. Again, very important to know the nuances and the difference, because really not all hormones are created equally. But the most important part for the purpose of this lecture, because there's a lot of information I'm trying to fit in here for you, is that bioidentical really what you want to use, because again, the data shows that bioidentical hormones, which we have tons of that are FDA approved products on the market or compounded, that they fared better even in the health outcomes that was reported by these large trials. So although bioidentical hormones, obviously, as I said, their exact chemical structure is what your body makes, they don't really meet the definition of natural, because again, they don't look like a yam or a soy. So where do these hormone receptors work? So obviously, when you look at the different estrogens, they have different affinities for the different estrogen receptors. So estrogen receptor alpha, and we have estrogen receptor beta. So estradiol binds to estrogen receptor alpha and estrogen receptor beta with the same strength. So estrogen receptor alpha is gas and estrogen receptor beta is the bridge. So with estradiol, the hope is the gas and the bridge equal. If you look at estrone, which is a stronger estrogen, at the estrogen receptor alpha, which is gas, and it binds less strongly to the estrogen receptor beta, which is Briggs. So most women in the menopausal stage make a lot more estrone, which really hits the gas and doesn't hit the Briggs as well. This is why it's very important as women are in the perimenopause and menopausal stage that we modify this estrone level through clearance, detoxification, but also balance out and make sure the estradiol is balanced. Estradiol tends to be more of the hormone of what we call during pregnancy, you make most of your estradiol. Although your body makes estradiol through the conversion through the COMT enzyme. And as you can see, estrogen receptor beta, estradiol, which is the weakest of the estrogens, binds to estrogen receptor beta, which is Breg, as compared to estrogen receptor alpha, which is the gas. So estradiol, breaking gas is even. Estrone, I hit the gas more, less on the brakes. Estriol, I hit the brakes more, less on the gas. And this is why God's textbook of medical physiology, as ITs, really made all these different levers and pulleys to balance out the estrogen and the effect on proliferation and breaks at the receptor level. Progesterone obviously mainly binds to the corticoid and glucocorticoid receptors a bit, but also obviously progesterone binds to progesterone alpha and progesterone beta. So again, same logic. So progesterone binds to alpha and beta with the same strength, and it binds to the glucocorticoid. That's why sometimes if you over or under progesterone, people will pee their brain out. This is why pregnant women pee a lot too, because of the effects of progesterone on the mineralocorticoid receptors. Now, when you look at the progestin, like medroxyproline acetate, you can see that it binds to the progesterone receptors alpha and beta much more tightly than progesterone, and it binds really strongly to the mineralocorticoid receptor. Testosterone clearly mostly binds to the androgen receptor, obviously slightly to the mineralocorticoid and the glucocorticoid, but mainly binds to the androgen receptor. So what do they do when they bind to these receptors? Obviously, estrogen really helps with vasomotor symptoms, cognitive improvement, mood improvement. Progesterone is very mood, neuroprotective, memory improvement, mood improvement. I always tease when women hit perimenopause or PMDD, I always tease, you don't have a Prozac deficiency, I promise. It's probably a progesterone deficiency. And you can see the effects of progestin are very counter-regulatory to the progesterone. So if progesterone helps with mood and memory, progestin usually causes impairment. Testosterone is also very protective to bone, brain, even breast tissue. So it's very important to really, whenever possible, to use bioidentical hormones. Now, estrogens in the body, your body makes three main estrogens. So estradiol, estrone, and estriol. And they're mainly made, obviously, by the follicle, the ovarian follicles. And then the body takes these through the different enzymes and converts it through the aromatase enzyme to testosterone and estradiol and to estrone. So estradiol production is really regulated by FSH and LH. And as I mentioned, really estriol is the hormone of pregnancy, although you make some outside of pregnancy. And estrone is the one you mostly make during menopause. All estrogen products are approved for these, which is the perimenopausal and menopausal symptom relief of vasomotor symptoms, for the prevention of osteoporosis, and some of the other genetic disorders that we have. And then obviously the contraceptives. So all contraceptives have STINs, which are synthetic progestogens, and estrogen derivatives. So most of the estrogen, really 2% of the circulating estradiol is free. And you have to have the free fraction or they can't bind to the receptor. So most hormones are actually carried through the body on a shuttle. So 60% bind to albumin, about 38% bind to sex hormone binding globulin, like testosterone also, and 2% is free floating. And that's the part that causes the cellular and physiological actions. So in the liver, estradiol, estrone, and estriol are converted to a bunch of water-soluble metabolites so you can pee them out. And that's why methylation, sulfation, glucuronidation reactions are very important to have a well-functioning phase 1 and phase 2 liver detox. But also, more importantly, all hormones undergo intrahepatic recirculation. So it's very important to have a healthy gut that is also that being mobilized, the patients are not constipated, because if they're not really also getting rid of the hormones through the urine and through the feces, they're going to build up on them and cause problems. And then obviously most of the secretion of estradiol, you'll start getting really in the follicular phase, you'll start secreting estrogen, and then it peaks at ovulation, and then it's maintained in the luteal phase. And obviously progesterone, which is the red line here, you make a little bit during the follicular phase, but you make the majority of it in the luteal phase. So on average, women secrete about 86 micrograms per day in the early follicular phase and about 380 micrograms for a couple days during ovulation and about 250 micrograms during the mid-luteal phase. After menopause, estrogen secretion declines to low level. Now, men also make estradiol and they secrete roughly about 50 micrograms per day. All hormones are very lipophilic, and as I mentioned, they bind to these estrogen receptors that we reviewed. And estradiol is definitely 10 times as potent as estrone and 100 times more potent than estriol. Remember, estriol is the weakest between all of the estrogens. So what do we have on the market? We have the patches, obviously you're very familiar. So the FDA products that are in patches are bioidentical. So a lot of times, and it really depends if it's a matrix or reservoir patch. If it's a matrix patch, you can cut the matrix patches. But if it's a reservoir, you cannot cut it, because sometimes they'll say, can I cut the patch and just use half if I don't need as much, or if they're trying to cut my dose? If it's a matrix patch, yes, you can. But if it's a reservoir, you cannot cut the patches. So also it's very important to notice that you will have different bioavailability, definitely when you use things transdermally versus oral, because all hormones are really undergo first pass to metabolism when you give them orally, and you will lose a lot in the process, if you will. So your liver then ends up with all these hormones that it doesn't need versus the rest of your body. That's why transdermal bioavailability is so much higher as compared to the oral. Now, the matrix technology patch that usually have a constant diffusion rate over 7 days. And some of the patches, obviously, you change twice weekly, right? So we tell patients Monday, Thursday, Tuesday, Friday, and so on. I will tell you a trick. I always tell patients to leave the old patch on for 12 hours to overlap with the new one so they don't have waxing and waning. And sometimes that gets them into hot flashes. And sometimes women will do a lot better if you do that. I always just have them press on the old patch so they know that's the one that should be peeled 12 to 24 hours after the new one is applied. Remember, the reservoir technology, you should not be cutting it. And also this one kind of slowly launches and it takes much longer to reach steady state. Most of the hormone patches are matrix, but you want to double check with your pharmacy before telling patients that they can cut it and things like that, because there's so many generics on the market now. Please also note that patient population, sometimes overweight, athletes, heat exposure, it's going to increase or decrease the release mechanism. If you have somebody that lives in the tundra, in Michigan when it's minus 40, sometimes in the winter, and all of a sudden they go to Florida and it's 80 plus degrees and they're in the sun, that may cause the release mechanism of the patch or the drug to be released more and the hormone. So they may have fluctuations, and depending on patients, if they have less fat or more fat, if they have less adipose tissue, they may have poor absorption, because usually hormones kind of depot in the fat, and then it's releases slowly to the rest of the body, if you will. There's also some gels. There's like the estrogels and other gels. Those are also bioidentical. Gel, Estrogen, and Estrogel. Again, those are bioidentical. Make sure that you're counseling patients if they apply these transdermally, that they could obviously cross-contaminate, or they can transfer some of these hormones to obviously male spouses or kids, animals, things like that. So you have to be careful that they're rubbing these on an area where it's covered, because even though it doesn't get absorbed right away, it will stay on skin surface sometimes for up to 2 hours. So you want to make sure that we're counseling patients about that. But again, these are 17 beta estradiol, and those are bioidentical, and those are FDA products that are available on the market. Oral, hopefully, if you learn nothing from this lecture, which I hope you learn more, you don't want to use oral estrogens because of all the side effects that we mentioned and the increased risk of clotting. There's also vaginal rings, and even sometimes now the oncologists don't pass out as much, if women are really having a hard time with menopause and cancer therapies and things like that, where they're using these very low dose. And I would prefer that you use the estrogen because it's bioidentical. But again, it releases very low amount. Now, can you still absorb some? Sure you can, but it's extremely low amount per day that's released and for local effect. Now, remember, the vagina is very vascular, right? So blood will go there and estrogen will be circulated in the body. But again, it's extremely minuscule doses. Now, if we look at progesterone is mainly secreted by the corpus luteum in the luteal phase. 2%, again, it's circulating progesterone is free, where 80% is bound to albumin, and 18% is bound to the corticosteroid binding globulin. So that's the same shuttle that binds cortisol. So again, it has to be free in order for it to work. So again, men make progesterone also, but not as much as women. And most of the progesterone, again, they'll release some, but most of it is secreted in the luteal phase, with the peak occurring at days 18 through 21 of cycle. So during a peak launch, most women will have a level of progesterone, blood progesterone of 18 to 20, and sometimes slightly higher nanograms per ml. Progesterone, again, very lipophilic, but this is why progesterone is such great for neuroprotection and also mood modulation, because progesterone binds to the GABA receptor. And the GABA, remember, is calm, peace, and bliss. Progestogens, like I mentioned earlier, that's the big class that houses the progestin, synthetic, and progesterone, bioidentical. So these are the different progestins that are on the market. So a lot of the birth control pills, or the mini pills, if you will, they have these different synthetic progestins in them. and progesterone is the only one that's bioidentical. So usually, unless you're dealing with DUB, you really don't want to use Provera because it does not have the same physiological effect or breast protective effect as compared to natural micronized progesterone. So remember, progesterone has a short half-life. That's why sometimes progesterone can be very helpful for perimenopausal insomnia. Sometimes it's very good at putting women to sleep, but sometimes they'll say, God, I wake up at 2 or 3 in the morning. And this is why, because the half-life is very short. And this is where sometimes compounded progesterone might be helpful because they can be made in a slower release and it can stay in there. Again, just for you to review, progesterone actions are very different on the body as compared to the progestins. So much better to use the bioidentical. And I mentioned progesterone is very important. Obviously, it has the anti-estrogen effect. So it's the brakes to the gas of the proliferation of progesterone, but it's also very neuroprotective, bone protective, heart protective. Be cautious of transdermal progesterone. There is really no data that has shown that transdermal progesterone confers endometrial protection. Okay. Now, vaginal progesterone has been shown to confer endometrial protection, but not transdermal. So if you're going to use transdermal progesterone, make sure that you're also using oral or vaginal for endometrial protection. And these are the studies that have shown that it really does not confer endometrial protection. And most of the data, what has shown is really 200 milligrams, 10 to 12 days per month, 100 milligrams daily, or 45 to 90 milligrams of vaginal progesterone for endometrial protection. That's what the data has shown. Pregnenolone, sometimes we'll check a blood level of pregnenolone, another very important hormone for really mood elevation, stress resistance. You can check it and then you can have pregnenolone compounded. Again, usually you want to start at 5 to 10 milligrams per day and slowly increase and monitor levels. DHEA is another adrenal hormone that a lot of people obviously lose as they get older. Again, for women, on average, they make about 5 milligrams per day. So on women, we recommend starting at 2.5 to 5 milligrams per day of DHEA for hormone replacement. Men need more if they're low. Usually men need 25 to 50 milligrams per day. There is a DHEA vaginal formulation that also works really well for incontinence, vaginal, obviously atrophy, sexual dysfunction, genitourinary symptoms of menopause. And there's been a lot of studies on this. This is the commercially available product, which is bioidentical, called Intra Rosa. But we've been compounding DHEA forever. So most of the studies showed 3 to 13 milligrams of vaginal DHEA is very good for the really genitourinary syndromes. So this one here, I put a table really for you to look at the milligram or microgram doses of hormones in the different phases, menstruation phases. And really, this should be your guiding light, if you will. When we replace women, these are mostly the doses you want to mimic, right? So this is where they came up with the progesterone, because 25 milligrams of ovary secreted works roughly to about 100 milligrams of oral progesterone. And if you look at the estradiol, really the patches have it right. 250 micrograms of estradiol in the mid-luteal phase. And that's most of your patches as you start dosing is 0.025 to 0.05 milligram patches. Or if you're going to use transdermally, you're using estradiol 0.5 to 0.75 milligrams. So what we're trying to do is mimic physiology. You always want to use transdermal estrogens. Progesterone is okay to use oral and is actually the preferred route to help with anxiety, depression, sleeplessness, and also most of the data for breast protection has been with oral progesterone. So here I just put a dose summary for you of what doses have been shown to be beneficial for heart, brain, and cognitive protection. Obviously, with estrogens, we do not recommend you do orally. Transdermal patches or creams are the way to go. Testosterone, most of the data for women looked at 150 to 300 micrograms transdermally per day. And the progesterone and DHEA we mentioned. Here, I just also put some kind of really general guidelines for conversion. If you have patients going for progesterone, for example, if they have a topical of 1 milligram, it would be 2 milligrams sublingual and about 4 to 5 milligrams orally. So just to kind of give you an idea, if you're trying to switch patients from different dosage forms. Also remember, when you use, definitely you can use vaginal administration of hormones, but please know that they don't stay in the vagina despite popular belief. Actually, if you look at this plasma level of progesterone, you actually get higher levels when they're administered vaginally, systemically, as even orally, because the oral, remember, it has a short half-life, so it's a quick up and a quick down. So the point is, if you're putting estradiol, sometimes they're using 2 to 4 milligrams intravaginally for just local effect. It's not staying locally. It is going systemically. If you use compounded hormones, so bias, if you see bias in the literature, that means it's 80% estriol and 20% estradiol. Most of the literature now, because of the beneficial effects of estrogen, we always recommend now that people use bias 50 and to use a bias 50-50, 1 milligram per gram. So meaning if you do 50% estradiol and 50% estriol, and that will give you the estradiol 0.5 milligram, which most of the studies have shown now that we need an estradiol patch of 0.025 to 0.05 milligram for bone protection, heart protection, brain protection, or estradiol transdermally 0.5 to 0.75 milligrams. And this is why we're now recommending that people, if you use bias 50-50, 1 milligram, which will give you estradiol 0.5 milligram, estriol 0.5 milligram, and then you obviously measure and adjust. So here I just really gave you some kind of general dosing guideline for PCOS, luteal phase defect, perimenopause, and just some sample prescriptions on how to write compounded hormones. Same for menopause. Now, estriol vaginally, this is great also for healing the vaginal mucosa. And most commonly it's used like at 0.5 milligram per gram. And then usually you apply it at bedtime for a couple of weeks, twice weekly for a couple of weeks, and then PRN as needed. This is another great formula for that. And sometimes adding a little bit of testosterone really helps. And the DHEA vaginal, again, if you want local effect. Now, if you replace people on hormones, should you test them? Now, most of the associations, really ACOG, Endocrine Society, tell you we should not measure hormones. And I was like, what? Would you guys ever give thyroid without measuring the hormone levels? Would you guys ever give insulin without measuring their sugars? So I think we need to measure hormones, make sure we're getting people into the sweet spot. Now, be cautious and know which assay your lab is using. This was really the old radioimmunoassay versus this LCMS. The new technology, which is liquid chromatography mass spec, it's much better because it's cleaner. It picks up more of the actual parent compound. It doesn't pick up a lot of the metabolites and noise. And it can also pick up very low levels of hormones. So you really want to use labs now that use LCMS for the hormone assessments. So how do you test hormones? Serum testing is really the gold standard in the literature. You can measure, obviously, other biomarkers besides hormones, thyroid, DHEA, so on. Requires the blood draw. Serum testing measures both free and protein-bound hormones. And remember, it's only the free that will do the action at the receptor. And also be cautious with transdermal hormones that really serum testing may give you an underrepresentation of the level because hormones don't live in the blood, they live on tissue. So the other thing with serum hormones is it only captures one point in time. It may underestimate the topical hormone delivery dose. And then obviously, if you're sticking a needle in somebody, you're checking their cortisol level, that may affect their stress hormone. Salivary testing, it's not, it measures bioavailable hormones, and it's really the gold standard for measuring cortisol. And even in the allopathic literature, it's that. So it's definitely, you want to get the 4-point cortisol. Very important to look at the cortisol curve. And you can only do that with salivary testing. Now, you don't want to use salivary testing if the patient is using buccal or troches. Obviously, if they just brush their teeth, you can't really correlate it with serum level. But this one, salivary testing, is more tissue level assessment. But sometimes caution with salivary testing is sometimes, especially progesterone, it likes to congregate in the saliva. So sometimes you get these really high conflated levels of hormones. Urine testing is great for looking at metabolites. So even if you do serum or urine testing, serum or salivary testing, you want to look at hormone metabolites at some point because you want to make sure everything is staying in the different aisle. Very important to look at estrogen metabolites and make sure that patients are not making up for hydroxyestrogens or the bad metabolite that actually can cause DNA damage. So very important to do urinary testing at some point. And remember, you want to use labs that use LCMS because really they're much cleaner now in checking really the parent compound and not necessarily the metabolites. Also here, I just put like suggested initial labs for you to check the patients. And depending on the situation, you can do a 28-day salivary testing of hormones, which is really nice. So if you have people with like fertility issues, a lot of irregular bleeding, you don't know what's going on, sometimes the 28-day salivary test is really nice. But you can do some blood or urinary testing. This is just a suggested female panel of just general wellness to really obtain. So the takeaways, I know I threw a lot at you. And again, we do tons of the A4M, or if you're not familiar with this, the American Academy of Anti-Aging and Regenerative Medicine, where we do 3 days on just even basic hormone. So I threw a lot at you in about 45 minutes. But the most important thing to remember is that hormones are not as vilified. They're very good. The risk really versus benefit. Now, the benefits far outweigh the risk. They are great for bone protection, brain protection, heart protection. You want to use them in physiological, so low doses, physiological doses. You want to use bioidentical and transdermal estrogens, oral micronized progesterone, testosterone if needed. You want to monitor and adjust therapy and definitely review each at the end of one patient. Review the potential risks and benefit for that patient for each one.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.